So we will now move on to the next speaker, and we can have Q&A in the end. So welcoming our second speaker, Dr. SUKRITI Thakur, consultant pathologist at Newburgh Sehgal Path Labs, Mumbai. She is MD in pathology from BJGMC and gold medalist in MUHS for MD pathology, and has completed her SRship in hematopathology from ACTREC in Tata. Over to you, Dr. SUKRITI.
Thank you so much. So I will be taking this opportunity to tell you some informative talk about B-cell acute lymphoblastic leukemia. Why I have chosen this topic, because it's one of the most common pediatric tumor, and it is the most common tumor we can see in the day-to-day life. So the right diagnosis is very important for a clinician and most important for the patient. So if we are able to, get the right diagnosis on the right time with the help of right team and with the help of corrective measurements, we can save the patient. So it's all about the integration, right? So once we get any slides, being a pathologist, we are always on the microscope, and we do see lots of CBCs, and we do see lots of peripheral smears. So on the basis of morphology, we are able to see what are the abnormal cells, what are the normal cells. So we are able to identify what are the blast, what are the non-blast cells. So once we see the morphology and once we interpret that these are abnormal, then we will ask our clinician to go for the further testing. These are the advanced tests which we are doing day-to-day life, and these are like immunophenotyping with the help of flow cytometry. Then we have cytogenetics, which will include basic conventional karyotyping and will include fish. And we have molecular testing, in which we basically doing the DNA and RNA testing with the help of next generation sequencing. So starting with the basic, I know many of you might be knowing what is flow cytometry. So flow cytometry is a term. If I break this term, this means that I am doing a cell morphology, but not directly on the microscopy, but in a different software, which will help me to identify a cell not only on the basis of its size and shape, but its antibodies also. So how we identify this? So I will be just showing you. Let me on the pen. Yeah. So what is the term flow cytometry? Flow means streaming, cyto means a cell, and metry means measurement. So I am basically measuring a cell when it is passing through a fluidic system of the flow cytometer, and we will identify a cell with the help of its property. So what are all these properties of the cells? So we can see there are physical as well as the chemical properties of a cell. The physical property mainly means that the cell has its size as well as its granularity. So if the cell has a small size, it will have a very low side scatter as well as the forward scatter. And if the size of the cell is more and it has more granules, it will have high side scatter in the side scatter as well as in the forward scatter. So we will see that our lymphocytes, which are very small in size and have very low granules in the cytoplasm, will have the side scatter and forward scatter very small. Whereas the monocytes, which are of medium size as well as have very fine granules, will have the medium side scatter as well as the forward scatter. Whereas our eosinophils, the neutrophils with the more size and more granularity will have high side scatter and the forward scatter and will lie here. So similarly, the cell have all the chemicals in it. It has surface, it has cytoplasmic, and it has the nuclear antigens. What are these antigens? Like for example, CD45. It is nothing but an antigen which is present in all the cells, right? So how I can identify this antigen? Yes, we can identify this antigen with the help of antibodies, and these antibodies are basically attached to the fluorochrome. Now, what are these fluorochromes or fluorophores? So these fluorophores or the fluorochromes are nothing but the these are, like, for example, these are the name as on the basis of which type of emission spectrum they will follow. So as you can see, as a cell pass, a specific wavelength of a light will fall on a cell. Once this light falls on a cell, this is called as the excitation of a cell. Once cell gets excited, the cell will absorb the energy of the light, and similarly at the same point it will emit the energy that is called as emission. So this excitation and emission will have some shift, which is known as stock shift. Now this stock shift will help us to see the cell which has been excited with which fluorochrome, and that will be analyzed with the specific software or the data which is present in a flow cytometer. So for example, FITC is one of the fluorochrome which will be get excited by the blue laser, which will be of wavelength, for example, 488 nanometer. Then we have another fluorochrome, which is like, for example, PE, which will be excited by yellow and green fluorochrome. Again, we have the red laser, which will be like exciting the per CP 5.5, PC7, APC, etc. And we have another laser, which is again a blue violet laser, which will be again exciting these particular fluorophores or fluorochromes. And again, we will be able to identify the specific antibody which will be attached to these fluorochromes. And in this way, the flow cytometer works. So for a pathologist, what is most important is a sample. Okay, if we get an adequate sample in a perfect tube, then the life becomes simple, right? So for us, EDTA, heparin, these two are the most important bulbs in which we do get the sample frequently for peripheral smear, for flow cytometry evaluation, for various molecular studies and cytogenetic studies. Now, WHO has already defined a lineage-specific markers. So these are the markers which will be present on the surface. These are the markers which will be present on the cytoplasm or in the nucleus. But each lineage, that is the B cell, T cell, myeloid cell, which are the main core of my hematopoietic system, they will be having specific lineage markers. So since I will be talking about B cell today, so for my B cell, what is a lineage specific marker? For my B cell, it is CD19 as well as CD79 alpha. These are the most specific B cell lineage markers which I will be seeing in flow cytometry, and it will help us to identify whether the particular cell is B cell leukemia or not. So on the basis of these markers only, we have in our lab designed a panel, that is the leukemia panel, which is basically specifying for like B markers, T markers, and myeloma. So for example, clinician calls me and asks me, hello, I want to do a test for a pediatric age group girl, and they are suspecting acute leukemia. So I will see the slide first, and I will add this leukemia panel, which will cover all the three main lineages of my body. That is my B cell, T cell, and the myeloma. So we have 6 to 12 color flow cytometry, and these all colors which I am specifying are FITC, PE, and these fluorochromes will have specifically present or attached to the antibodies, and these antibodies I will be identifying on the flow cytometer. So in this way, the whole diagnosis is made on the flow cytometer. Now coming to the what are the B cells, where they are made, and how they mature. So B cells are nothing but the cells which are formed in bone marrow. From bone marrow, they go to the peripheral blood. From peripheral blood, they go to the lymph node and mature. So basically, our journey starts from the bone marrow and ends in the lymph node. And the very mature cells, for example, the plasma cells, they come back to the bone marrow, that is the home. So I can see here the three main categories: immature B cells, mature B cells, and the terminal B cells. So there is a terminology called as hematogons. Hematogons have been termed to the very early B cell precursors, and they have been divided into stage 0, stage 1, and stage 2 hematogons. I will just tell you the importance of these staging. Then we have mature B cells. These mature B cells will pass through the lymph node and will form from transitional B cells to the memory B cells. And as the memory B cells, they become more, when they become exposed to the antigen, they will switch and then they will start forming the antibodies, and those are called as plasma cells. So in this way, the whole journey of the B cells happen. Again, so why the cells are important, and like why I'm emphasizing on the journey of B cells, because each cell from where it is maturing has its origin for some disease, like my pro B cells or P B cells or my immature B cells, which are present in my bone marrow, have more tendency to transfer into leukemia or B lymphoblastic leukemia/lymphoma. Once they mature and they reside in the lymph node, they are more have the tendency to become abnormal in the form of lymphomas, that is mature B cell neoplasm. But as they become very terminal, they become the plasma cell, then they will trigger to formation of multiple myeloma or plasma cell neoplasm. So each and every cell can lead to a abnormal cell, and that abnormal cell can make a big disease. So as I told you, hematogons, it's a term which has been given to the B cells precursor. So each cell has its own antigen, right? So earlier the cell, it will be more immature, it will be more closer to the stem cell phenotype, right? So like for example, CD34 is an immature marker. CD38 again is an immature marker. TDT is an again immature marker. So my early cells like immature or pre-pro B cells, they will tend to like exhibit these immature markers. But as I see, as my B cells mature and they mature towards mature B cells, they tend to lose these immature markers and start gaining the mature markers. For example, CD20. CD20 is the mature marker. They will tend to gain kappa lambda, which is again the marker of maturity. So this is very important because on the flow point of view, when we see a cell, whether it's immature and mature, we should know what all the markers do they exhibit. CD34 is coming, it means it's a progenitor cell. It means these are blasts. But if the 34 is negative and 45 is coming very bright to moderate, it means that they are mature cells. They are not my abnormal blasts. So we have to be very careful while seeing these cells, and we should be very much aware of these markers. So WHO has recently classified BLL on the basis, entirely on the basis of cytogenetics, because it's the cytogenetics right now which gives the prognostication whether the patient lies in the high risk standardization or in the low risk or in the intermediate risk. So it's all about the cytogenetics, right? But the older classification we all are aware of, that is the FACT classification. It is entirely the morphological classification in which they have classified L1, L2, L3 type blasts, in which the L1 are very immature cells which are very small in size, very condensed cytoplasm, very condensed nuclear chromatin, and very scant cytoplasm. Whereas the L2 blasts are little larger, right? They are little larger. The cytoplasm will be moderate and may have sometimes vacuolation. But whereas the L3 blasts are very large blasts, Again, they will be full of cytoplasmic vacuolation, and they are more commonly seen in Burkitt lymphoma. So for now, if we are focusing on BALL, we will be seeing more L1 and L2 type of blasts. So since we are starting a case-based presentation, I will be showing you one case. So a 4-year-old girl presented with generalized weakness, fatigue, and abdominal pain since 5 days. On examination, there was the vitals were normal. She was currently afebrile, but she had the history of on and on fever since again 5 days. And on per abdominal examination, patient had mild hepatosplenomegaly. Now, why the history is important in these cases? I can see it's a history of only 5 days. It's an acute onset. It's not the patient is suffering from something from months or years. It's just a acute illness which I have to see. So this is very important. So I asked for the peripheral smear and the CBC, and we got the CBC, and we ran the CBC in the Sysmex machine, and it showed us WBC count of 58,000, which is very, very high for even the 4-year-old girl. So 58,000 with the anemia, that because the HB is only 8, and with the thrombocytopenia, that is platelet is even less than 50,000. So basically, we have bicytopenia with leukocytosis. So I saw this scattergram. Now, what does this scattergram helps? So we can see that a normal scattergram will show us 4 population. We can see eosinophils with a high side forward scatter, and we have neutrophils, we have monocytes, and we have lymphocytes, right? But what I can see here is there is a huge cluster of approximately 70 to 80%, which are lying in approximately like lymphocytic region, and they are going towards upwards. It means that they are like medium to large size cells, right? So this is not normal. I can see this is normal, this is not normal. So we saw the morphology. Okay, on morpho, we can see these small to medium sized cells, which are not looking like lymphocytes, of course, because the chromatin is again very condensed and very, very scant cytoplasm is there. And these cells were appear to be blasts, which were approximately 89%. So yes, my dear friends, this case had acute leukemia. So we as a pathologist tell our clinician that this is acute leukemia. Now what next? What we will do next to specify what type of leukemia it is. And here comes the role of flow cytometer. So we will add the specific cocktail which I have showed you, that acute leukemia panel was added in this case. And similarly, the markers which I have showed you, that it showed a beautiful immature marker, that is the CD34 positivity with the bright CD10, with the bright CD19 and 38, and almost dim to negative CD45. So this is the population of my interest, which are my blasts and which are abnormal. So I will tell my clinician that yes, the patient is suffering from BLL. So that's it. Is that the story ends here? No. So we know that, as I told you before, the prognostication has been done for BLL cases by the DFM protocol, and it has been categorized by standard risk, intermediate risk, and high risk. So me being a pathologist can help a clinician that what is the prognosis of BLL? Yes, of course I can help them, but how I will help them? See, the most important thing here is the diploidy, right? So what is a ploidy? The ploidy is nothing but the replication of a cell or a abnormal cell to normal cell, that how fast they are being replicating, as well as how many number of chromosomes they are showing. Okay, so for example, in my case, the patient has high hypodiploid. So normally what happens is we have a diploid case, we have hyperdiploid case, or we have hypodiploid case. And with the help of flow cytometry, with the help of using FX cycle violet dye, we can tell on flow only that whether the patient is diploid is hypodiploid or is hyperdiploid. And why it is important? Because it takes only and only 7 to 8 hours. Whereas a normal cytogenetics, okay, which will be given by the cytogenetist, and the fish report will take another 5 to 6 days. So this was the conventional karyotyping report of this case, which has confirmed that yes, patient is having high hypodiploid, but we, being a pathologist, we gave the report as soon as possible, and it helped the patient's stratification. Now, another thing which is very again important for BLL cases is whether the patient is having BCR-ABL1 positivity or whether the patient is having Philadelphia-like abnormality. Now, another flow cytometer markers which are helping us these days are like CD25, which is a very important marker. And if this marker is positive, which is negative in this case, but if it becomes positive, then it is a slightly possible that patient might be BCR-ABL1 positive BLA. Okay. Another marker which is a TSLP marker, which is nothing but the thymic stromal lipoprotein marker. So this is a specific protein which is secreted by CRLF2 gene. And if this TSLP is present in blast, okay, if it comes positive, it means my patient will have CRLF2 gene rearrangement, and it means the patient is PH-like phenotype. So why PH and PH-like phenotype is important? Because they are poor prognosis. They are in the high standard risk. So these patients will have later on may have relapse or may do not respond completely to the treatment. So this is very important to specify. And with the help of flow cytometry, we are helping these patients to get to know as soon as possible that whether they are standing in the high risk zone or in the low risk zone. So after we are done with our flow cytometry, we send the sample to the cytogenetics lab, and in the cytogenetics lab, they do this conventional karyotyping and they do the fish. So in the fish, we have the various, probes in which they will see the different types of rearrangements. Like most common with the good prognosis is ETV6 RUNX1 gene rearrangement, KMT2A MLL gene rearrangement. So these are the gene rearrangements which will be seen by fish, and we also be covering all the pH-like gene arrangements also. So after the flow, so it's like stepwise. Again, the morpho we saw, then we saw the flow, then we went to the fish. Now coming to the molecular. So these days, people are going for the NGS DNA and RNA testing. But why? Clinician is calling me, why are you suggesting NGS DNA and RNA test for a simple DLL case? Okay, the first thing is that it helps us the confirmation, that it helps us to confirm that whatever the mutation which has come in the fish, like for my patient in this case, the fish report was positive for 1221 translocation, that is EPV6 RUNX1 translocation, and it has been confirmed by NGS DNA RNA. Okay, now case closed. But what are those cases in which sometimes fish fails to tell us the answer? That means there are few fusions proteins which are not being able to pick up by RNA. So we have to go for the RNA testing, we have to go for DNA testing, and those fusions are, and they are long list. So we have to be very careful. So what we do here in our lab is, we send the sample for fish. Fish comes positive, okay. But what about the RNA thing? RNA gets destroyed within 2 days, okay. The preservation of RNA is very important. So we send the RNA preservation to our another lab for the molecular testing. So till the date fish report comes, we keep our RNA preserved. If fish fails to answer, we'll go for the RNA sequencing, and these all the RNA fusions as well as DNA genes which we will be able to pick it up. So in this way, we get a complete diagnosis of a BLA. So from morphology morpho to flow, flow to cytogenetics, cytogenetics to molecule. So now there are something which is being like on flow only. We have to be very careful while reading BLL, because BLL is one of the most easy case to pick, but most notorious case also, because we sometimes overcall a case as a BLL, but sometimes it can be something else also, or it can be something MPAL also, like mixed phenotypic acute leukemia also. So WHO has given a criteria. He says, if you have a strong expression of CD19, good, just go for another add-on marker for the expression, say CD10, CD79 alpha or CD20. But if the CD19 expression is weak, then you need a help of two another markers. That is again CD10, CD79 alpha or CD20. So this is the WHO criteria and we follow this criteria. So another case which will be again a BLL case, but why it is important I will tell you. Again, a 43-year-old female, it's an elderly female, came to us with a history of fever, abdominal pain with pancytopenia since 1 month. Patient has received transfusion maybe because of the pancytopenia, and outside peripheral smear reported atypical cells and blasts. So clinician calls me and says that the patient peripheral smear has been reported as atypical cells periblast, but can you confirm it on bone marrow? The patient's bone marrow was done and we got the bone marrow aspirate slides and we could see the big cells and few small cells, but these all are abnormal cells, but the chromatin is very condensed, and these are more likely the L2 like blasts, which are like little larger. So again, we did the flow cytometry, and the flow cytometry, as I told you, has a specific markers. The panel is already being fixed. So we did run our acute leukemia panel in this. But here the 45 was very bright. I was like not very much convinced whether they are blast or whether they are lymphoma, because the immaturity is defined by 45 negativity or 45 dim. But 45 here, it was very good. Okay, I was like, okay, it's fine. Then I saw CD10. CD10 was completely negative. Okay, CD10 negative. Then I went to CD34. CD34 is coming, but it's only coming in subset. The majority of my blasts are negative for CD34. Again, I was very much, like in dilemma. Okay, now this is the issue. Somewhere it's going. But the 19 was good. Okay, and 20 was dead negative in this case. Okay, let's see. So again, WHO helped me here because he says that we have to add an additional marker, 79 alpha and CD22. So we added 79 alpha and 22 and it came out to be good, moderate, positive. So it helped me because morphologically they were blast. And on flow, there were certain markers which were not coming. But I had to, give the proper diagnosis. Okay, so it came out to be pro-BLL. How do we define pro-BLL? Pro-BLL are basically 10 negative and 34 is usually coming in a subset or they can be dead negative. So we assume that this could be a KMT2A rearrangement, BLL, because the KMT2A MLL gene rearrangement DLL are usually 10 negative and 34 is usually negative in those blasts. So I asked my clinician that you should go for fish, and in fish it is possible that it can be KMT2A, and fortunately, but not good for the patient because these are the poor prognosis DLL, and the fish came out to be KMT2A positive, and we were happy that we were able to give the diagnosis as well as prognostication on the basis of only flu. So as Dr. Urmil ma'am has already spoken about, the measurable residual disease is the upcoming thing. Not so upcoming, but yes, it has been established, well established in labs and everything. We are doing MRDs for DLL, TLL, AML MRDs, and we are doing multiple myeloma MRDs. So basically, MRDs is all about the picking up the very small cells or very small disease from the pool of normal cells. Okay, picking up a disease is like picking up a big chunk of disease from a very normal cell, small normal cell, and MRD is just opposite of that. Okay, so we do MRDs with different techniques. We do it by flow cytometry, we do it with the PCR, we do it with the NGS. Okay, so these three are the parameters or modalities with which we are doing MRDs. And what are the stages of MRDs? For BMRD, I will be specifying here. So it's a post-induction, we have post-consolidation, and during the maintenance and the pre-transplant. So post-induction like day 35 for 5 weeks, post-consolidation like 42 days or 6 weeks. Then we have maintenance in the period of 2 years. The patient will have like 6 monthly or yearly MRD test kit being done. So for MRD, for BMRD, it has been labeled the clinician. For a clinician point of view, the clinical MRD, which is important, is 0.01%. Okay, so less than 0.01%, it won't be clinical significant, but we as a pathologist, we have the disease. Okay, but it will depend on the clinician now. If it is a post-induction marrow, then we might do the, of course, we will be going ahead with the post-consolidation thing. But if it is a post-consolidation and is still getting 0.01% disease, then again the re-intensification and everything will be done, and so on. So on flow again, we have the MRD being done, and it is a very sensitive and specific technique for MRDs also. But for that, you have to be, majorly specified to understand the normal maturation patterns, right? So what is the normal, what is the abnormal? Because it is very difficult to separate those disease in the population of normal cells. So here I can see, as I told you before, hematogonts, okay, the precursor B cells basically. So hematogonts, which are stage 1, 2, then maturing towards B cells. Here in the T and here in the CD10 and 20 plot, you can see a beautiful waterfall pattern, and we have been like studying this waterfall pattern since long. So the pink population is my stage 1 hematogonts, which are CD10 brighter. And as they mature towards B cells and become stage 2 hematogon, they lose CD10 and they become stage 2 hematogon. And as they mature towards complete mature B cells, they will lose CD10 and they will become mature B cells and CD20 bright. So in this way, the maturation goes on. Similarly, you can see stage 1 are my immature cells, the first precursor form. So they will show CD34 positivity. So as they mature towards stage 2, they will lose CD34 and will become only positive for CD10. And as they mature towards B cell, they will be only and only positive for CD20 or 45, and they will lose immaturity markers like 34 and 10. So this is the MRD positive case which came to us, and you can see the population in 4 different colors. You can see mature B cells which are blue. Then we have the pink cells which are basically earliest precursor form of normal B cells like stage 1 hematogons. We have cyan blue color which are stage 2 hematogons, and this whole chunk which is 45 dead negative but 10 moderate positive is my disease. So this disease came out to be approximately 0.02%, and we gave it as MRD. And we tend to, compare this phenotype, which is coming currently, with the diagnostic phenotype, because sometimes what happens, there is immunomodulation. So the disease which was previously 34 negative can become 34 positive, or vice versa. Like with the disease which was 34 positive can become 34 negative, or the disease which was 34 negative can become 34 positive. So this is basically the immune modulation in the sense, once the chemo goes, the cell starts, changing its proteins and fusions, and the antigen expression changes over the cells. So it is very important. Do not ignore any small cluster you are suspicious of. Always compare the MRD disease which you are giving with the diagnostic phenotype, because both can be different. Now today we all are aware of immunotherapies which we are getting, and it's a bliss for the patients, blinatumab, CAR-T. right? So Blina and CAR-T has, played a very immense role in today's response to the BLL, especially the refractory BLLs or the BLLs which are being relapsed. Okay, so on being a flow cytometrist, what is important for us is to know or to understand what all the population which is coming positive, is it 100% positive or it is not? Because these targeted therapies are for some reason targeting the cell antigen. Okay, if it is targeting CD19 and if my blasts are CD19 negative, then what is the point of giving the target therapy, right? So we should understand that if CD19 is being targeted, my blast should be approximately 98% positive for the CD19. But if my blast is like 50% positive and 50% negative, it means that that candidate or that patient should not be given Blina or CAR-T, because irrespective of giving these immunotherapies or targeted therapies, the patient might not respond. Okay, so we can see in India, in Tata only, the CAR-T therapy has been held a lot of BLL cases in the pediatric age group, and we get CAR-T CAR-T MRDs from lot of places from all over India, and we have a very unique panel for CAR-T, because we can't see CD19 positive cells at all. It's a different panel, it's a different gating strategies. But yes, of course, it is not the right time to talk about it, because it's again a long, a talk about CAR-T and how do we analyze it in the CAR-T patients and everything. But that's all from my side. Thank you so much.
Thank you, Dr. Sukriti. And it was a very interesting session.